Hello, everybody. Welcome to Wound Care Gurus Facebook Live. We are bringing you an exciting new event again tonight. We've got a great interviewee. We're excited to hear what he's got to share with everybody. I think it's just going to be a really great informational opportunity for you. We're going to be talking about a very hot topic tonight. We're going to be talking about wound infections. I would, again, highly encourage you all, please type in your questions at any time into your chat box. We are happy to, our guest is more than willing to take questions on the fly. So a couple of things though, before I get too far into the interview, I want to first bring up just our advanced wound debridement schedule. We've got classes coming up. So if you haven't signed up yet, we still have room in every one of these locations. Obviously, we don't have our fall schedule up yet at this point, and that won't be coming up till a little bit later this year yet before we start putting that up. But we've got some great locations coming up. And so I just encourage y'all to register early because we are limited in all these hotels to spacing because COVID restrictions are still in place. And maybe by some of them later on, they may relax them. We don't know. But just giving you that heads up, check it all out at sharpdebridement.com. And then I also want to bring up our webinar that's coming up next week, Wednesday. If you haven't registered yet, you can go to our website, Wound Care Gurus. It is a free webinar. It is being sponsored by Anacapa Technologies. And it's going to be it's called Antimicrobials. Are you getting what you paid for? Anything and everything you ever wanted to know about antimicrobials, we're going to be covering it in that webinar. It is chock full of information, totally, completely non-biased. We'll not be talking about specific brand names or anything. We're just going to talk about the different types of agents and chemicals and products they put in these different products to make them antimicrobial or not. So it's going to be an awesome, awesome webinar. So I want to encourage you to share that with your friends, your colleagues. It's going to be a great event. If you sign up in advance, even if you miss it, because you can't make that time, you still will be able to go back and watch it for free after. So that's always good. People like free. So anyway, so even if you're like, I can't do February 3rd, register. It will be available on demand for pre-registered people to come back and watch it for free. So anyways, so that's kind of what's coming up. I'm excited. I am going to bring our guest here on board. Let me bring up, there he is. There is Dr. Miguel Mateos. Doctor, how are you doing this evening?
Hey, Bill, how are you? Thanks for having me.
Hey, thanks for coming on board. We certainly appreciate it. Taking time away. I know you've got a busy schedule. Just a little history from our viewing audience. I met Dr. Mateos at a wound conference last year, and we struck up a conversation. And with his background, I thought he would make a perfect guest on our Wound Care Gurus Live to talk about our topic tonight, which is the wound really infected? So I'm just going to refer to you as Doc, if that's okay with you. But how about if we start out?
Perfect.
That's fine. Awesome.
You
How about if
just
we
froze
start
for a
out?
second. You
What's
just
that?
froze for 1 second. You just froze for 1 second. I hope it doesn't happen when I'm talking in my computer. So,
No worries about it. So,
okay.
how about we start out with you kind of telling us a little bit about your background, Doctor?
Sure. Well, I've been in medicine for 40 years. I finished medical school 40 years ago. It's a long time. I'm an old timer. I did my internal medicine training in Cleveland Clinic, and then I did some my infectious diseases training at University of Miami and Jackson Memorial. And I've been practicing infectious diseases for 32 years. I'm in Melbourne, Florida, and I've been in private practice since then. And I've been taking care of wounds pretty much for 32 years, basically. But I was really not wound certified or specifically, and now these days you need certain certifications. So that's why took the course that you gave, and now I'm wound care certified. So
Awesome.
I'm happy to do that, and it's just definitely an exciting field.
Yeah.
So
There's always a lot going on in wound care. So,
absolutely.
and I really appreciate, like I said, when I met you in class and you told me that you were infectious disease background. Um, Obviously, we talk about that in the course, and we were pretty much on the same page for most things. And like I said, I thought, you know what, we have never had an infectious disease physician on Wound Care Gurus Live, and I thought you would be able to share some of your own personal experience and insights. I mean, you're telling me you got 40 years experience as a physician, 30 years plus in infectious disease. So I'm sure you've got a wealth of wisdom to give with our audience. So
I want to think so. I want to think so.
well, it's the gray hair, doc. That really
There
means
you go.
that's what the wisdom is.
Exactly. There you go.
So
There you
let's
go.
start with my first question, and that
Okay.
is: in your experience, are chronic wounds really infected as often as they are diagnosed to be so often by your colleagues?
No, I really don't think so. I really think that there is a way too overdiagnosis of wound infections, and and the reason why is a number. I mean, there are several reasons, and the main reason, in my opinion, is that um, in general, the medical personnel, and that includes physicians, colleagues of mine, they get a culture result and they equate the culture result, the positive culture result, with infection, which is not the case.
Right.
A culture result is just reflects, growth of a bacteria, and you and I know that if you swab just about anything in this world, you're going to get a positive culture.
Sure.
So
Mm-hmm.
the importance of knowing what to do with a culture is exactly the interpretation. I mean, how was this culture obtained? Why was this culture obtained? Why did they
Sure.
order it? I tell the nurses all the time when they call me to see a patient because of a wound infection. I said, well, why was the culture done? Was the culture done because there was something different? Was there new drainage? Was there, redness? Was there any of the signs of infection that we usually know are potential problems?
Mm-hmm.
And if the answer is no to all of those, I said, well, why did they do a culture? Well, the doctor just ordered a culture, because it's an open wound. And my answer is, well, anything you swab is going to grow something. So, the reality, you have to understand the difference between a positive culture, meaning the patient is colonized,
Mm-hmm.
with bacteria, which we all are,
Right.
or the patient has an infection. So that's the main difference. And I think that to answer your question, there's an overdiagnosis of wound infections because people in general do not know how to interpret the results of the cultures. Most of the times, the person who orders the culture maybe hasn't even looked at the wound, and that's the other thing. A physician gets called and told that there is drainage from a wound. Well, certain wounds are always going to have certain amount of drainage. You can't avoid that. Again, so if you culture that just because of there's presence of drainage, and then you get a result, what's going to happen is, we all know, you get a medical, you get a culture result that gets placed in the medical record of the patient,
Sure.
and everybody's saying, hey, are we going to treat the patient? And I'm saying, well, what are you treating? Are you treating the patient, or you're treating the culture? Because I treat my patients. I don't treat the culture results. So you have to
Right.
know what you're doing, but people are very uncomfortable just knowing that there is a result of a culture that no one is technically doing something about. And I think that's where the overdiagnosis, and unfortunately, with the overdiagnosis comes the overtreatment. And we know well that use and abuse of antibiotics in everywhere pretty much, but in this country is a real problem. I
Sure.
mean, the CDC has reported that up to 50% of hospitalized patients receiving antibiotics are receiving antibiotics that should not be given. They're inappropriate.
Right.
And in nursing homes, the numbers go up to 75%.
Wow.
75% of people in nursing homes at one time or another receiving antibiotics are not being treated properly. They're getting something they shouldn't be getting.
Sure.
And of course, there are complications from the use of antibiotics, and we all know it. We have a significant amount of multiple drug-resistant organisms.
Right.
It's a serious problem. There's over the CDC also reports more than 200,000 people getting side effects and complications from the use of antibiotics,
Mm-hmm.
and with that, not an insignificant number of deaths. 20 plus
Yep.
thousand deaths from complications. So it is a serious issue. I mean, people need to understand that, using antibiotics is a serious business.
Mm-hmm.
And I find myself after 32 years of being in this business, more often than not, trying to stop antibiotic treatment that have been started by other physicians than starting antibiotics. I'm more cautious these days. Yeah, I'm more cautious these days who I start on antibiotics. I mean, and I think that we all physicians in general need to adopt that practice.
Right.
Using antibiotics should be something that is a last resort and well thought, not just a knee jerk
Sure.
reaction and oh, we have a culture, let's start this. And the same goes for other infections. Urinary tract infections are notorious, specifically in nursing homes. Everybody gets a urinalysis and culture, and the results come back and everybody gets treated regardless of whether the patient truly has any real symptomatology of a urine infection.
Right.
So
Mm-hmm.
it is a problem. It is a
Got it.
problem,
Okay.
definitely.
Cool. So, I mean, kind of a follow-up question to that. I mean, why do you feel so many prescribing clinicians today are still using traditional swab cultures despite the evidence that they're not quote unquote diagnostic because they can't quantifiably measure how much bacteria is actually there? So why are they using this old tool that, I mean, even the Department of Health and Human Services has said it's an inappropriate, and they've said it 20 some plus years ago. Why do they continue where is this practice coming from that we just use this swab and they consider that diagnostic?
Well, you're correct. I mean, it is something that has been known for quite some time. Unfortunately, I have to tell you that medicine has changed a lot in the last 30 years that I've been practicing infectious diseases, and the reality is that there's a number of things that physicians do almost automatically that you know keep being done regardless of what you just said, that it's been proven that is not as effective. So I would say the reasons that people still do that are probably several. Also, one is perhaps lack of knowledge of what you're saying.
Mm-hmm.
People may not know that that the real more efficient way of culturing the wound is by doing a quantitative culture, not
Mm-hmm.
just a swab. And some people probably don't know that. I have to say that. And the other is because swab cultures in reality are simpler.
Sure.
They're more practical. They're
Mm-hmm.
available, widely available, and people can grab them anytime and do it.
Right.
When you're talking about a quantitative culture, which usually means a biopsy, a punch biopsy. You need the right person that is qualified to do the biopsy. You need a laboratory that is used to deal with this type of cultures and do
Mm-hmm.
quantitative culture.
Right.
Because in all reality, I'm telling you, by working in hospitals for all these years, the laboratories that hospitals have are not used to deal with some of these things.
Sure.
Maybe if you are in a university setting, or academics is but most small community hospitals do not have laboratories that are equipped or used to deal with some of this type of cultures that are the best ones to do quantitative. So I think that's part of the problem. So if you ask me why do they still do that, it's probably those are the reasons. It's just simpler, it's there, and the others are a little more complicated to do. Everything is time consuming. Remember, my friend, these days, most of us in the healthcare business spend our time in front of a computer screen,
Right.
documenting and doing the things that we're probably not very happy of doing, but we have to do.
Sure.
And years ago, the same time used to be spent at the bedside with the patient, and
Right.
that goes for nurses, that goes for everybody in healthcare. So we don't, sometimes there is not enough time to do certain things, so you opt for the simplest and fastest one available to you, and that's the truth.
I
It
mean, it
doesn't
makes
mean it's the
sense.
best. It doesn't mean it's the best, but
Sure.
it's what it is. It is what it is.
Yeah.
So.
I guess, I mean, maybe in a way it's kind of like they feel like they're doing something. It,
Well,
it
yeah,
may not be the right thing, but they're like, at least they
exactly.
go to bed going, well, I did something. So,
Exactly. Now, again, the importance, in my opinion, is know how to interpret those results.
right.
That is the important part. If you know where the culture came from and how it was done, then you have a little better understanding of what those results mean and whether you really need to treat that patient for an infection or not.
Sure. That makes a lot of sense.
And here comes another thing that is not uncommon. They call the physician to tell him that the wound is draining. The physician happens to be a physician on call or covering for another physician who's really the doctor that is in charge of that particular patient. So the covering doctor orders a culture. The real physician taking care of that patient has never seen that wound or is not aware of it. So you have a combination of things. The person ordering the culture is not the one taking care of the patient, and
Right.
the one that receives the results is the other doctor, and sometimes he doesn't know any better than we have a culture result. There's a problem. There's an infection. We have to treat it. You
Right.
know. So yeah,
Yeah.
it's a common problem.
Okay.
Yeah,
Again, it sounds like there's a little breakdown in communication.
it is.
The the
Unfortunately, yes.
the lack of continuity in care sometimes can obviously lead to this type of
It
a
is
situation. So, well,
definitely.
good. Well, let's move on. I know that you had a couple of things that you wanted to show. Is there anything of those that you wanted to talk about now before I move to
Yeah,
my next
yeah,
question?
we can. Yeah, we can put those slides.
You talked
Just
some about this. Yeah, this was the
yes,
first
yes,
one.
yes. So basically, with this, you it's also important for people to understand when we're talking about wound infections is that we are talking about two different type of wounds. Of course, acute wounds, which are mostly surgical wounds, are obviously much different than chronic wounds. Two different animals to deal with, and of course they can both get infected, but the way they present is probably very, very different. So we're now basically going to concentrate more on chronic wound infections, and as you can see here, it's a very significant problem, and they have a high amount of morbidity, economically, the cost for the system, and the risk for the patients, because an infected wound can progress from a simple infected wound to sepsis. You can put the next one.
Sure.
And this is the important thing that everybody needs to understand, that most chronic wounds are indeed colonized by a number of bacteria, and this is what polymicrobial means. And So obtaining cultures of a wound, again, if you don't know how the wound culture was obtained, can lead um, to the wrong diagnosis, and again, as we mentioned originally, to overtreatment. Um, you know, the reality is that anything that we culture can grow something, and the important thing is to, as already mentioned, to differentiate what is colonizing versus what's really infection. Um,
Right.
I can tell you that after being in medicine for all these years, you know, there's still a fair amount of confusion between even between physicians and medical personnel, nurses, of what colonization means for a patient. And I debate this all the time when, oh, the question is, oh, he's colonized with MRSA. Oh, so he's good. We can take him over isolation. And the answer is, no, we can't. People do not understand that colonization means that you have a bacteria in somewhere in your body that's sitting there, but it's not causing you any harm,
Right.
but it's there, and and being there is capable of being, yeah, transmitted to somebody else.
Sure.
So when I tell people the patient is colonized with MRSA, that only means the patient is not suffering any effects from the
Right.
MRSA, but he is able to transmit that to somebody else.
Gotcha.
So therefore the patient needs to remain on isolation. So yeah, there's a little bit of a confusion on this when people say, oh, he's only colonized, he's good. Well,
Right.
it's good. It's good for the patient. Being colonized is good for the patient. We are all colonized
Right.
with bacteria everywhere. I mean, our mouth, our GI tract has got millions of different bacteria. I mean, but that's the way it's meant to be.
Right.
They have a function, they have a job to do, and there is normal to have those. Certain other bacteria is not normal to have them.
Right.
So, but they can still be sitting there, not causing any harm, and that's what colonization really means.
Gotcha. So, what should somebody look for in a wound to really suspect that it's infected? What would, in your opinion, as an infectious disease doc, what do you want the nurse or the therapist to call you with and tell you that's like, you know what? That really would be something I want to do some further investigation into.
Sure. Well, again, you need to decide, are we dealing with an acute wound, a surgical incision, a surgical wound, or a chronic wound? I mean, some of the symptoms and signs of infection are going to be similar. Of course, if you have a closed incision, I think it's a little simpler and easier to detect an infection because obviously the skin is closed, and you shouldn't have any problems. And
Right.
if you start having, if you start seeing development of edema of the wound, erythema, which is redness of the wound, increased temperature around the area of the wound, and of course, drainage of purulent material. Obviously, all those are signs of an infection. Now, in a chronic wound, it's a little bit different. It's
Okay.
not as easy because of what we just said. The wounds are colonized with bacteria, so they already have bacteria. How do you know that there's a new infection there? And of course, some of the signs will be similar. There's still going to be perhaps some redness around the area, some swelling. There's going to be poor progression of the wound. The wound is not going to be healing at the same speed it used to be before it became infected. There's going to be perhaps a drainage with an odor, with a smell that you're going to detect. And as I learned from you in the class, you need to clean those wounds before you decide that it smells, because most wounds after they've been covered with a dressing will smell.
Sure.
So you need to clean the base of the wound and then find out if there's indeed those changes. Now, when the wounds are really, progressing and getting more infected, there's other signs. There's surrounding cellulitis of the area of the wound. There can be what we call lymphangitis, which are those red streaks that can be basically that signals that the infection is getting worse, is progressing. There can be crepitance, which means there's air under the tissue, that's a bad sign. If you have something like that, that's a really bad sign. That means there's an anaerobic organism, a bacteria that grows under lack of oxygen. That's what an anaerobic bacteria is.
Right.
And there's going to be air under the tissues. And most of those infections are really serious. I'm sure that most people have heard of the infection called necrotizing fasciitis. People that have had this infection, there's a variant of that called Fournier's gangrene, and they're life-threatening infections. Those
Right.
infections need to be, diagnosed rather rapidly. They need to be attended immediately because most of those patients require aggressive surgery to clean, debride the area, remove dead tissue and infected tissue, and of course, aggressive treatment with antibiotics. Other signs of serious infection obviously are the classic, the patient with a fever, patient with an elevated white blood cell count, evidence of perhaps a patient becoming septic with hypotension, low blood pressure, tachycardia, tachypnea, all the signs of an infectious process progressing. But I can tell you that I just saw not too long ago a lady who had Fournier's gangrene, and she had 7 surgeries so far. Seven.
Wow.
She's a morbidly obese lady with diabetes, which is usually one of the main
Two big risk factors right there.
associated risk factor for that, and she has had 7 surgeries to debride her wound. Now her wound looks actually nice. It's humongous. It's huge. I mean, it involves half of her lower abdomen. It's incredible when you see that. But it's clean. But it took 7 surgeries to get where she is.
Wow.
So that, there are serious problems. So.
Sure. Well, we got a couple of questions that came in from the audience related to some of the stuff that you've already talked about. So I want to pick those up. So
sure.
One gal asks, how do we interpret the culture results then when a swab is done? Based on when you do a swab, how should you really interpret those results?
Well, again, we go back to the same principle. First of all, is the person that took the culture knows why was the culture obtained? Do they know the wound? Because that's also important. When you're following a patient, there's got to be continuity of care. You have to know what does that wound look like. Because again, just getting a culture result doesn't tell me much. You have to know the results of the culture, and you have to know what does that wound look like and what has been the evolution of that wound. If the wound has been doing poorly, if it's not progressing the way it should be, and again, if there are other associated symptoms that we just mentioned, then obviously you give a little more meaning to that culture results.
Gotcha.
And knowing that, you have to, we will talk a little bit about later of the culture techniques that should be best. I mean, they're not perfect, but the way to really obtain a culture that might be the best way to avoid obtaining just colonization or bacteria that are sitting on top of the wound.
Sure.
There's some techniques that you can do. So.
Good. Another question was regarding when you were talking about the MRSA thing. It says, well, what if there is no more drainage, but you're still finishing the antibiotics for MRSA? Do we still have to discharge, or do we have to discharge isolation?
Well, isolation is, again, as long as the patient has a positive culture, I would think that you need to continue isolation. Now, if the patient has no drainage anymore, there's nothing, and the wound is closed, and it's concealed, depending on which facility you're in, they might want the patient to get off isolation. I have to tell you, with all of this situation we have this last year, 2020, and COVID, my friend, and even before that, with the amount of people in hospitals with drug-resistant infections, MRSA, MRSA, VRE. Now we have a large number of people with this bacteria called ESBL. Positive organisms, E. coli, they're very resistant.
Right.
With all those, we have a shortage of isolation rooms.
Sure.
Most facilities do not have the luxury of having private rooms for everybody. I
Right.
mean, some do, some don't. And when they don't, I mean, then you're stuck. You have to keep a patient in a semi-private room with another neighbor, and unfortunately the other person might be at risk for this. So it's just kind of complicated. But that's why there's infection control, and there's infection control nurses, and that's what they do. Now, one thing I was going to mention before, and I didn't, there are certain facilities, and I happen to see patients in one of them. Is called an LTAC, long-term acute care hospital, and those are the kind of hospitals that get people on ventilators, and they keep them for a long time. People with rather large wounds, complicated wounds, people that still require to be on antibiotics, and in this particular facility, for example, every patient that gets admitted gets a culture. If they have a wound, they get a culture from the wound, regardless of whether it looks infected or not. They get a culture from if they have a tracheostomy, they get a culture from the sputum. If they have a Foley catheter, they get a culture from the urine. Now, those cultures are called surveillance cultures, and the reason we do them is so that we know who came into that facility already having certain infections like MRSA, VRE, some of the resistant organisms. So there is a reason to do those cultures, and people need to interpret those with caution, because they meant to be done just to know what the patient was colonized with. They were not meant to be done because the patients were infected. So and that's when people need to understand the difference, because if you just look at the result of the culture and you don't know why was it done, there's going to be somebody very anxious to pull the trigger and say, "Oh, we need to treat this." Yeah,
Yeah.
it always happens. It always happens. So
We did a culture. There must be a reason. We got to do something now that
exactly,
we have a culture.
exactly. Yeah, we can't
Well,
we can't let this untreated.
yeah, exactly. Another question. It says, and I'm just going to kind of paraphrase it because there was a question and a comment. If the wound is covered and it cultures with MRSA, and as long as the wound is covered, do they need to isolate the entire patient, or is it good just with the wound securely covered if it's wound MRSA?
Well, I'll tell you that there have been studies through the years. I mean, way before my time, my friend, where they use that blue light, that fluorescent light,
Okay.
um, and they were able to document that if a patient has MRSA or staph, just forget MRSA. I mean, just regular staphylococcus in a wound, and they do a fluorescent light all over the patient's body, that thing is all over.
Mhm.
I don't care if the wound is covered or not.
Okay.
The staphylococcus is a contact organism, and all it takes, and I'm sure that we've all seen now with this COVID, what happens with COVID. You touch this, you touch that, and it gets spread. So the fact that you have a wound covered is good, it's nice. It doesn't mean the patient does not have the capability of transmitting that MRSA to another person, and that's why they should remain on isolation.
Gotcha. Okay. Good. All right. So getting back to what we were talking about, when would you suspect? So, in your opinion, then, what do you think, or what do you use to truly define a wound infection that requires aggressive treatment?
Well, aggressive treatment, that would be when we were just talking about, if somebody has, besides the 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 findings of the wound that are, the edema, the erythema, the increased pain, and all of those signs that we just mentioned. If the patient also has a fever, if the patient has an elevated white blood cell count, if there's evidence of sepsis, ongoing sepsis, that's when you have to act immediately and start treating that patient with antibiotics. And at that point you get a number of other tests, including blood cultures, because it's not uncommon for certain of this and certain infections that start in a wound to become generalized and cause septicemia.
Gotcha.
So basically, that's what you need to be cognizant of and be attentive. Now, it doesn't, I'm not going to tell you it happens all the time. I mean, for all the wounds that I see, in reality, not very, very few people that I see end up being septic, but it does happen. So you need to be on the look for it.
Okay, good. So let's kind of shift gears now and kind of talk about the different, types of culturing that is done. Obviously, we know the punch biopsy has been the gold standard in confirming wound infections. How prevalent is that? And I get the question all the time from students is, well, why don't the doctors do it more often? If it's really the gold standard that truly confirms you can get a true quantitative analysis, why won't they do them more?
Well, going back to what I mentioned before, unfortunately, um, first, lack of training. People are not trained. You need to have the knowledge of how to do that.
Mm-hmm.
You just can't just walk in and say, okay, I'm going to do a punch biopsy, and I have no clue how to do it, but I'm going to try. It doesn't work like that. You have to have at least experience doing that, and not very few people, in my opinion, probably have. Maybe, obviously, if you're a surgeon, I'm sure that you can do it.
Sure.
But if you're not a surgical person, I'm sure you didn't receive any training on that.
Mm-hmm.
So the first part of the answer to your question is lack of training, lack of the proper person to do the punch biopsy. That's going to be the main thing.
Okay.
The second part is again, it's an invasive procedure.
Mm-hmm.
So a swab is very simple, very relatively painless, I would say, for the most part. Whereas doing a punch biopsy, of course, inflicts cutting, and you, to get a decent sample, you need to get a deep part of the wound. So
Sure.
obviously, it's going to be a painful procedure,
Sure.
and it's invasive.
Didn't you sent me something on kind of the details on doing a punch biopsy
Yeah,
that I thought.
yeah. There you go. There you go. So as we're talking about, it's invasive, it's painful, it's more expensive. Okay, so what I said before, it's still true. In this day and age of the kind of medicine that we practice, and everybody's moving fast, and nobody's spending too much time at the bedside, to do a procedure that is going to take, longer time, the specialized equipment, and of course, somebody who is knowledgeable about enough to do it. It takes time. So it's most of the times, the clinician just says, hey, just get a culture, just get a swab. The nurses don't know any better. They just said, get a swab of the culture. Most of the times the physician is not the one doing the culture, which it could be a problem if the nurse doesn't know how to do it.
Sure.
If the nurse doesn't, if you're dealing with a wound care nurse, that's a different story, because I in the short time that I've been doing now, dealing with more wound care since my training and certification, I found out that the wound care nurses that are well trained will do of course, the right cultures. They would do it in the right fashion. They most of them don't do punch biopsies, that's for sure, but
Sure.
they would do the culture with the Levine technique, which we also have a slide there
Yep. I'll
of
pull that up.
that's the Levine technique, which is supposed to be the proper way to culture a wound. You clean it, you dry the bed of the wound, and you go, and exactly like it says there, you spin your applicator and over a 1 centimeter or 1 centimeter area, and then squeeze and push and express whatever amount of fluid is there. and send that for culture. I mean, is not as good as getting a deep tissue
Mhm.
biopsy, but it's better than just swabbing the wound, you
Sure.
know, the top of the wound. So now, in other circumstances, you can also do a needle biopsy, and I think that there's also a slide regarding that. You know, a needle biopsy is a little bit less invasive than a punch biopsy, and that was something that most physicians could do. I done quite a few of those, um, and basically you just tried to obtain fluid going on the side of the wound, you know, and try to get as much fluid as you can and put it in a submit it in a culture swab, and that may be um, giving you more information that just a simple swab from the
Mhm.
top of the wound.
Sure. Okay.
Um, so now, you have asked me or mentioned about newer techniques.
Yeah.
Uh,
Do you have any experience? I mean, or what do what's your opinion on? I mean, there's the big hot thing out there right now. There's two things that are out there. Um, there is the moleculite, which I know that we talked. You've not used it,
no, no,
and it's
no.
just it's a fluorescent type thing, and it just shows surface bacteria. But from my understanding, it only lights up the wound if there. I think there has to be like a 10 to the 4th log worth of bacteria. Otherwise, you won't see anything because there's not enough. Okay,
Yeah,
but again,
yeah.
it's
I'm
not
not
really
familiar
a
with that.
yeah, it's really not a diagnostic tool for infection. It just says here's how bad the amount of bacteria is sitting on the surface, and that can help guide people to clean and debride superficially to help remove some of that. That's I think the
Sure,
main.
sure.
What we had a physician on a couple weeks ago with the Perilov irrigation system, and he's a former surgeon, and he was saying that he uses the moleculite so he can see where the bioburden is the heaviest. So that's where he focuses more of his irrigation and his debridement, so he can clean out that mess, so to speak. So, but the
Yes,
other one,
it seems to me that that technique is more useful to do what you're describing, more the debridement, sharp debridement,
right,
or the lavage, rather than a diagnostic
right.
thing.
Yeah, I don't think that they claim it's for diagnosing
Yeah,
anything because it can't tell you. It has to be. I think again, if I remember our interview with them, I think they said it had to be at least 10 to the 4 log, or it wouldn't
yeah,
register. But that doesn't mean it couldn't be 10 to the 10. It
sure.
doesn't tell you that when you look at the wound. It's more of a visual guide. Now the other one that I did mention or talk to you about is the PCR, the
Yeah,
polymerase chain reaction testing. Some people call it
yeah,
DNA testing, RNA
yeah,
testing.
yeah.
Um, what are your thoughts on that particular technology to be used maybe as another alternative?
Well, the first thing I would say is that I do not have experience with it. I would say that,
Okay.
but I have been reading about it since you and I talk about it, and I've been getting some feedback just from the literature, and it seems to be an exciting technique, new technique. I mean, we all hear about PCR these days. I mean, that since COVID, everybody's a doctor at home. Everybody's in the medical business these days. Where everybody knows about PCR and rapid testing and
Uh-huh.
antigen testing. Everybody's throwing this, an antibody level, and even my kids, it's like, hey, wait a minute, they want to argue with me now. It's like, are you kidding me? You know, so, but yeah, it's all of this terminology has now been thrown around very easily. But polymerase PCR stands for polymerase chain reaction, and what that is basically a technique that amplifies DNA. So what these companies are saying and promoting as far as their product is that you can swab a wound, and even if you don't have live organisms, even if they're dead, they can still get DNA from those organisms, analyze them, multiply them, and amplify them, and get the name of the organism, of the bacteria.
Mhm.
Now, that sounds very good. Now, the exciting part about that is that they claim to have results in about 24 hours, which is obviously definitely much faster than a routine culture
Sure.
is. Now, the problem I'm having, and they from what I read, is how do they test those bacteria against antibiotics? And of course, the traditional culture, if people understand what a culture really is, you get a culture, you get a sample, you put it in a swab, it gets to the laboratory. The technician usually, puts it in a petri dish, you know, um, plants it and puts it in an incubator. Well, it has to be usually spent overnight. It's not quite 24 hours, but overnight. And if there's usually some growth of bacteria, they will know the next day. And once they have some growth, that sample is put into a machine, which now these days most hospitals have automated machines. In the old times, what they used to do is they would have to grow that in another petri dish and put this antibiotic discs to do the sensitivity. So
Uh-huh.
you would determine whether a bacteria was sensitive to something or not by how large the area around that disc was. They used to measure it in millimeters. So if the area was beyond certain millimeters, you say, oh, that's a sensitive, that antibiotic killed enough of that bacteria. So that's the way it used to be. Now,
Oh,
once in a while these days, they still do that for certain antibiotics, but for the most part, everything is now automated in machines. They put that sample in a little machine. It's a computerized machine that has, I don't know how many antibiotics, maybe 15 or more, and they stick it into the machine. The machine incubates it overnight, and the next day, the machine spits out the result. So some of the people that promoting this PCR, I heard that the spill that they were doing, and they were claiming that cultures could take up to 10 days. That's not a reality. Most cultures, from the time they get to the laboratory to the time you get a diagnosis can be, perhaps 72 hours, 3 days. So yeah, it's not fast, but it's not quite 10 days. Now, the PCR, when they test for antibiotics, they're actually not testing activity for the antibiotics. What they're doing is they're testing the genome of the bacteria and trying to find out if there are some genes that determine resistance to
okay.
certain antibiotics. So
Gotcha.
they're not quite testing. And to me, that's a little bit of a problem. Interpretation of those results could be a little tricky because
Sure.
you're really not getting a measure of how much is that how good is that antibiotic. When you do the technique that I mentioned before, the traditional
Right.
culture,
Sure.
we get a number. We get a number based on the concentration of the antibody. It's called MIC, minimum inhibitory concentration. So that gives you the minimum amount of antibiotic that's going to kill that germ.
Gotcha.
With the PCR, you don't get that.
Sure.
You only get information that says, well, this bacteria may be resistant to penicillins, to this or to that, but it doesn't tell you how much of the other antibiotics that supposedly work will take to kill that bacteria. And
Good point.
that could be a problem. It could
Okay.
be a
Sure.
problem because it doesn't quite tell you. We when we read the cultures,
Mhm.
we have a, if you remember, people read it's got an S that stands for sensitive.
Mhm.
There's an I for intermediate, and there's an R for resistant, and
Right.
that's based on the amount of concentration of the antibiotic. With the PCR, you don't get that. You
So
don't
what you're
get.
what so what you're saying is it could lead to the possibility of either underdosing or overdosing an antibiotic to treat an infection.
Potentially, I mean, potentially you could be using an antibiotic that may be this far from being resistant, but because the technique doesn't test for that, it only tests for the genomes that cause resistance. You think you're okay. So I think that maybe in the future it will be better. Maybe in the
Sure.
future they will have a way to find out certain more ways to determine if an antibiotic really is effective or not. But the way it's described right now and the couple of things that I saw it sounds to me that it's still there are certain things that are more useful or informative with the current culture that we use, the traditional culture. And I know that they've been around forever, but sometimes stuff that's been around forever still works.
Sure.
I
Oh
hate
yeah.
to say it.
No,
I hate to say it.
some stuff still is good,
Hey,
even
don't
today.
break it. There's no broken, buddy.
No, I'm just gonna throw a shout out. We have one of my audience, and I know her very well. Renee is on there, and she asked a question, but I need a little clarification. She asked, "How are they overcoming this problem?" Now, Renee, can you clarify that for us? Which problem? The PCR not being able to do it, just so I know exactly what you want to know from Dr. Mateos. Um, what does this mean? Overcoming this problem. Because he's listed a whole bunch of them, so I want to make sure we address the right problem that you're asking about. So, in the meantime, while I'm waiting for Renee to clarify that question for us, what have you found to be probably the most effective strategies to treat chronic wound infections?
Well, that's a tough one. That's a tough one. Hey, you know that better than me because you've been doing wound care for many, many, many years. Um, again, I think that it's just perhaps repeating myself, but you need to have somebody who knows the wound. There's got to be continuity of care in a wound, because if you take care of the wound today and I take care of the wound tomorrow, and Peter comes back the next time, guess what? Neither one of us is going to have the same information or eyes. I mean, we can have a little bit of an idea, but we're not going to have the same view of how that wound looked from the beginning. And for me to say, at the end, if I'm the third person to say, oh, that wound is getting worse, I don't have any reference. I really don't. I mean, because I wasn't. But if I saw the wound at the beginning and then I saw it again and I saw it now, well, it definitely, there's something to be said in medicine for, just about everything. But continuity of care, it is very important. So if you know that wound is not progressing the way it should be, you know that there is a potential problem with infection, then of course you need to act accordingly. And that might be by changing the way your dressings, the dressings you're using, the antiseptics you're using, and if you think that at some point, based on the results of a properly done culture, you need to start antibiotics. Well, if the wound seems to be only infected, but there's no other systemic symptoms,
Sure.
there's oral antibiotics are probably appropriate. If obviously there is more serious symptomatology and evidence of fever, hypotension, and other things that make you suspicious for potential development of sepsis, then obviously you need to start more aggressive therapy with perhaps intravenous therapy.
Okay. So her question to clarify is because you were talking about how, how do they know then if they're using a PCR to get their sensitivity or lack of sensitivity, their resistance? Do you have any idea what they might be doing to overcome not knowing how to dose? Or is they just kind of closing their eyes and taking a shot in the dark? I don't know.
Again, the first statement I said is I am not experienced with this technique, so
Sure.
I can't really tell you what is that they are doing to try to solve that. I'm not even sure that they think for them it's a problem. I'm not sure. I mean, again, remember, I mean, these companies are trying to sell you something. Which I'm sure they're making good money from.
Sure.
So they're not going to tell you I mean, they're going to try to give you as much information as possible, but they're not going to turn you down by telling you, well, we can't really tell you the amount of antibiotic you need, whether that antibiotic that I'm telling you is okay may become resistant. Because the reality that is if we were to do a real culture, we would know that it's almost resistant. So it's a little bit of different information that we're playing with here.
Sure. Well, let me ask you
I
this.
don't have any problem with the rapid. I mean, it's great to have rapid identification. It's great to have some information as far as which antibodies may not work. But I believe that maybe we might need to use a combination of both. Maybe we might need to use a combination of the and the traditional cultures, because I'm not sure that the PCR alone is going to give us all the information
Sure.
that we want.
Nothing is exactly perfect, is it?
No, and then and at this point, the PCR, the problem I see with it is, number one, it is more expensive. Number two, is not perform in most hospitals. You will probably have to contract with a company
Sure.
that will provide you the service, and they'll and I know that they can give you all the supplies, and they can give you all the Federal Express envelopes so that you can send this stuff overnight,
Right.
and all that stuff. But the reality is that it's as I said before, is going out of out of your way, is not the routine. Hospitals are not used to do that. Hospitals, these days they want everything simplified. Everything,
Sure. Mm-hmm.
and remember, patients that used to stay there 2 or 3 days for observation of this or that, they looked at, and then less than 24 hours they're out of the hospital. People are having surgery as an outpatient all the time now. There's to be in the hospital these days, you really need to be very sick, because otherwise they kick you out right away. It's not like it used to be. So
Sure.
they don't want to deal with doing expensive, tests that are not available in house.
Right.
That's the reality. So it's a little cumbersome. It's an extra step. So I can see a little problem with that. Maybe if the laboratories inside the hospital would do it, maybe that would be different.
Right. Well, let me.
But it's not going to happen.
Okay, I'm gonna put you on the spot. Okay, not too bad, but and again, I know, and for the audience sake, this is purely speculative what I'm gonna ask, but I'm just curious. So let's just say, for example, with your experience, your knowledge, if you were a physician using the PCR as the result, but not knowing how to appropriately dose, what do you think, or how would you, in a methodical way, come up with a way to do that? I'm not saying, again, we're not going to
No,
put you on the spot that, hey, but I'd be
yeah.
curious what your thoughts on that would be. Is how should somebody kind of mentally process through that to come to a good conclusion?
Well, maybe let me clear something, because maybe we have a little. I said something maybe was misinterpreted. There's not dosing of antibiotics is kind of standardized, to be honest with you.
Okay.
We dose we dose a certain antibiotic, and we know what the dose should be, and so that's not going to change whether we have PCR or not. What will, in my opinion, what might be a little different is that, again, when you're looking at the routine culture, the way we used to look at it, there's certain antibiotics that may be right on the borderline
Mm-hmm.
between being resistant and sensitive, being active or inactive.
Okay.
And I am not sure the PCR is going to be able to tell us that. That's what
Gotcha. I see
I
what
was
you're saying.
trying to say.
Okay.
It's not about dosing. The dose is going to be the same regardless of, the same dose I'm giving you. The antibiotics are all standard as far as the
Okay.
dose. Some of them are given based on your weight. Some of them are based,
Mm-hmm.
but that's not going to change. My point of view was, there might be certain instances where you might think that you're using an antibiotic that is going to be really effective, when if you had the other technique, you would realize that it's this far from not being effective.
Gotcha.
And
Okay.
that's where I have a little problem. So,
Perfect. Awesome. Thank you for that clarification. So we got one more question from the audience. Okay. All right. And I'm going to add a little bit, just a couple of thoughts onto it myself. The question is, they're asking you if you can speak to topical antibiotic application for treatment with the culture and sensitivity. Now, before you answer, I want to throw one thing out there for the audience, and that is, when you're dealing with chronic wounds, there's little evidence of any topical antibiotics being effective in chronic wounds. They're perfectly fine for acute injuries, but in chronic wounds, other than mupirocin, which still only has limited evidence it's effective, most of the other ones have not shown really any effectiveness. But even with, let's just say, mupirocin, can you kind of speak to the application of antibiotic therapy and culture and sensitivity?
I think that what you just said is exactly the answer I would give. I think that topical antibiotics in general have limited use for this type of wounds. You're right. If in an acute setting, an acute care, an acute wound might be a little different. But in a chronic wound that we know is colonized with God knows how many different bacteria and yeast and fungus and all kinds of stuff, using a topical antibiotic is, I think is, I would tell you, is treating more the doctor or whoever prescribed it than the patient.
Sure.
It's for the peace of mind of the person writing the order. I don't think that is doing much. I think that keeping the wound clean and doing what you would otherwise do with the wound is appropriate. I've seen people using gentamicin, ointment in the wound, and unfortunately, it's not without risk, because that is going to favor the development of resistance to gentamicin,
Sure.
probably. And maybe if you need it in the future, you're not going to be able to use that because you already burned it. So I think that in general, the use of topical antibiotics is for mild stuff, to be honest with you.
Sure.
I don't think antibiotics are meant, are not terribly effective by contact. I think that you need to be they need to be in your system to deal with infections. I mean, when we treat people with osteomyelitis, we treat people for 6 to 8 weeks with intravenous antibiotics.
Right.
So that gives you an idea. This is the amount of antibiotic that we are trying to get into your system to kill that infection is significant, and it needs to be given for a long time. So giving something just on top of the wound is obviously not going to have similar effect.
Sure.
Excellent.
Good point. And I appreciate that clarification. That was excellent. So, well, listen, Doc, it has been awesome. I think I've got some great comments. I'll share them with you after the show. But we got some really good feedback. We got some great questions. I want to thank our audience that tuned in live tonight. We certainly always appreciate that. Doc, I just want to say thanks again for your time.
Hey,
and
pleasure.
I really
Thanks
appreciate
for having
it.
me.
You bet. And it was really good seeing you again. And we'll chat in a little bit, but I'm going to let you go for now. And thanks again for joining us here at Wound Care Gurus.
Thank you, Bill.
All right. Good night.
Bye-bye. Good night.
Well, everybody, that concludes our interview for tonight. I hope that you found it to be helpful information. I know I certainly learned a lot. I mean, I thought I knew a lot, kind of spent a lot of my research looking into antimicrobials and dealing with wound infections. So I just found it really interesting to get a perspective from somebody with his background. So anyways, I want to just say thanks everybody for tuning in. This will be, of course, available for stream. So share it with your colleagues. They may find it helpful and beneficial in their practice. So with that, everybody, I'm going to let you all go. Have a great night. We'll see you next time on Wound Care Gurus Facebook Live.